We're going to have a quick run through. This is obviously a huge topic, so this is what I'm going to try and cover in the talk. Please stop me at the end or whatever if there are things I haven't covered to your satisfaction. The reason I show this example of the most unimpressive osteoma in the world is just that it shows you where it starts, you know, that junction of the frontal bone coming down into the ethmoid complex, and you can see why it so easily causes problems with drainage of the frontal sinus, and so they get mucocoeles. And a lot of the complications from these either arise from mass effect, where they impinge upon the extraocular muscles or stop movement of the eye, you get double vision, that kind of thing, or occasionally they can erode through the walls of the sinus, and therefore you get a conduit for infection to come in, and so they can be complicated by infection. And you can see this is a really horrific case of cerebral abscess with ventriculitis. The large arrow at the bottom there showing the debris within the lateral ventricle just sort of like layering at the back. So they can actually be more serious than they usually are, but we need to keep an eye on them. Another bony issue that we can get, here's a skullbase lesion on MR. It looks like an aggressive, big, expansile tumour. But what I want to, if you take nothing away from this talk other than this, it's that when you're doing skullbase, CT and MR are complementary. And this is quite obviously this ground glass appearance here on the CT. No way are you going to call that anything other than fibrous dysplasia in a young patient. There's just no way. But the MR, as I say, is quite worrying. And this is just the T2 actually. When you're looking at texture, often T2 gives a lot of textural information. And again, that's how it looks on that's the comparison between the MR and CT. Not dissimilar, I guess, is another skull-based, anterior skull-based tumour. This is a Ewings sarcoma. I'm not saying I see this on a daily basis, but we do see anterior skull-based tumours, and often they're kind of, there's not much difference often between them. So some of the squamous cell carcinomas arising from the ethmoidal air cells can sometimes show very little in the way of necrosis, and then you get this uniform enhancing tissue, and it, to be honest, can look very similar. So I don't tend to get too bogged down in trying to tell you guys what the histology is. I try and describe the anatomy, and obviously there's going to be a biopsy anyway, and that's what's going to give definitive histology. And just for comparison, really, you know, you can see how these have that patient with the fibrous dysplasia again. These have a tendency to get over-reported, and they happen not every year. We get one of these or two of these. It's sent into the MDT where people have queried high-grade tumours, and obviously it turns out not to be. Okay, moving on then. So infection then. As you can see, there's a very obvious breach in the posterior wall of the frontal sinus here. This is in a situation of somebody with polyposis and pansinusitis. The important thing is, once you get to that point, is to move on to MR, okay, because MR is a lot more sensitive for picking up these extraaxial collections intracranially, okay, than CT. So if you're concerned, if you've got meningitic symptoms, it's MR and post-contrast MR that you really ought to be doing. You can underreport CT quite easily in these situations. And this is just another more florid example where somebody's got a really rip-roaring meningitis. Normally in meningitis you don't see anything, but in this case it was so appallingly bad that you can see enhancement in all the sulci where the pus and all the associated vascular changes are accumulating. When we're looking at these leaks, we use cisternography. You can see that these are quite complicated. I mean, it's kind of like, yes, these films are taken, these plain films in cisternography, but to be honest, the thing we pay attention to is this. This is more to do with positioning, making sure we get in contrast where we want it to be with the positioning of the patient. And this is actually what leads to diagnosis. And the position of the patient is very important in cisternography, and so it's very important that you tell us where you think the leak might be coming from. And what we'll also do is usually a CT pre-examination, pre-cisternography, to look for obvious places where we need to investigate further to make sure that we get the patient in the right position to enable gravity to help push, pull, whatever you want to call it, the contrast through the gap that you think is there. Don't remember. Just remember, we don't do it until the meningitis, the infection has settled, and it's a specialist examination. So we have one person here in Sheffield, my colleague Charles Wawrowski, who does all of ours because there isn't enough to share them around, and so you get de-skilled when you're not doing them on a regular basis. So it's a specialist examination, and that specialist examinations have a requirement, in my view, that they need a good history, because they're complicated things, and that's why they're kind of specialist examinations, really. Okay, moving on to tumours. Meningiomas, what can I say about meningiomas? Extraaxial, durally based. You can see that there's often this kind of capping cyst appearance over the top, yeah. Iso-intense on T1, and this is the CT, again, very similar kind of density to brain tissue. Frequently calcified if they're calcified, or if you get hyperostosis, which is where it induces this thickening of the skull, that's very, very helpful. It's unusual to find circumstances in which you get hyperostosis from other causes. Because we can do multiplanar imaging with MR, please do make use of that, and you can see that this is the so-called dural tail. Anything that irritates the dura and is abutting it can actually theoretically cause a dural tail. So it's not a specific feature. So if you see a dural tail, that does not equal meningioma. There are other things that could cause it. Dural-based Mets, for example, particularly think about that in the case of women with breast cancer. It's not that uncommon. And this is just a close-up just to show you that angle, that obtuse angle that you get with extraaxial lesions. Where you get interaxial lesions contacting the dural surface, it tends to be a more acute angle than that. Okay, so here's a typical, not unusual kind of CT, but there's bone missing. Get nervous. When you can't see bone on a CT with the sinuses, get nervous. Start thinking about what could be there. And if you guys have got any suspicion whatsoever about these cases, if there's anything unusual when you look, we need to be doing MR. And if you do MR, then you might find something like this. This is an olfactory neuroblastoma. You can see that it strongly enhances, not dissimilar to all those other ones that I've just shown you earlier part of the talk. And so there's nothing terribly specific about it. You can see relatively bright T2 signal. One thing to remember about these olfactory neuroblastomas is not only can they present with neck nodes, but also they can recur in neck nodes. So you need to do neck imaging, not just skull-base imaging. This is a juvenile angiofibroma, and sometimes these get confused by trainees. But remember, there are several things that are significantly different, okay? Loads of flow voids, a bit like paraganglioma, which we'll come to later on in these talks. So they're very, very vascular tumours. This is much more inferior and posterior compared to what I've just shown you, okay? So that's, again, a significant difference between the two. And often they start around the Sphenoid foramen, and so there's early invasion of the pterygopalatine fossa, so you need to be looking around here. I'll cover the anatomy of the pterygopalatine fossa in a moment. It's a very important area, and so that's a route for which these, if they present late, can sometimes get up into the orbit. And we do occasionally get cases that are that advanced. So just something to think about. If you see something that looks incredibly vascular when you're looking at it, go for CT and MR, sure, but make sure we do the MR. Just a reminder, when you're looking at your sinus CT, there is this component above them called the brain-like, and so just remember to have a look. You'd be surprised how often tumours get missed in the anterior cranial fossa on these CTs. Right, okay. Central skull base then. This CT was reported as normal. Now, is it normal? Well, perhaps in retrospect, you would say, well, look, what's all this gunk in the sphenoid there? That's not normal, is it? It's much more obvious, though, when you do the MR scan. So just another example, just reinforcing this idea of MR and CT are complementary in the skull base. Now this happened to be TB, and obviously depending on which part of the world you work in, this will be either a rare or more common diagnosis. But you can see you don't see much intracranially apart from this dural enhancement in TB of the sinuses, and that's fairly unusual. But you do get cranial nerve palsies as it causes problems in the cavernous sinus. You can get pyogenic infections, and they can be very serious, obviously. You can get fungal infections, and obviously you're always looking for the characteristic signal changes on T1, where you get bright signal on T1, but to be honest, they're pretty uncommon. But you can get dramatic cases like this one, where you've got loads of sort of daughter abscesses arising from that central skull base infection. All right, so mucocoeles, we're all used to seeing them in the frontal sinus. Just remember, they can occur in more unusual places. This was a sphenoid mucocoele, and you can see it's got a kind of weird appearance, but it's got all the characteristics for it. It shows an expansion, and there's no, actually could show post-contrast imaging, there is no enhancement from this thing. It's a very bland-looking change. Okay. When they do get infected, some of these mucocoeles can be fairly dramatic, and you know, there's no way you could separate this from the case of the TB. You know, so please, you know, imaging is not that specific in a lot of cases at the skull base. It's just so you've got to delineate anatomy, and sometimes when you delineate the anatomy, that gives you clues as the differential diagnosis rather than the imaging characteristics. Okay, this is a major topic in its own right, and for me, occupies much more of my time than most of the rest do, actually. So skull-base invasion, and this is very much around nerve roots, so you've got to know your nerve root anatomy. Obviously, you've got to know the trigeminal nerves, and I guess you all do, but just remember the routes they're taking, and therefore the directions you're expecting tumour to spread in. So we have quite a large practice of adenoid cystic carcinomas in Sheffield, which we get from across the north of the UK, and those, for example, are particularly prone to neural spread, and you can get skip lesions. So you can have completely normal-looking nerve root, and then 2, 3, 4 centimeters away from the primary lesion, you can get spread of the tumour. So you do need to review, or someone needs to review, the whole length of the trigeminal nerve when that's the diagnosis, for sure. This is just a bit of anatomy then. So this is Foramen Rotundum, which we talked about in terms of E2, and this is Pterygopalatine fossa in the coronal plane. The whole of this is Pterygopalatine fossa in the coronal plane, and you can see there is nothing between Pterygopalatine fossa and the orbital apex other than fat, and so it has enormous implications. If there's tumour in the Pterygopalatine fossa, to get clearance of that with a margin at surgery ends up implying that the patient would need a orbital exenteration going right the way back. So that's a really massive operation and may not be appropriate. So it's very important that, from a radiology point of view, that we get this right for you. And it's something that if you're worried about clinically from the basis of the patient's symptoms, you need to be on our case saying, well, is there, have a look for it. Pterygopalatine fossa. Now, again, this is something that, you know, when I'm teaching the first year registrars, they get a bit upset about because it seem to find it difficult. If you think about an axial plane image, here's the air in the maxillary antrum. Go back, hit fat, Pterygopalatine fossa. Just keep it as simple as that, okay? Don't worry about trying to learn all the complex anatomy of this. You know, you can see that it's multi. You know, it's curved in a mediolateral direction. It's curved in a craniocaudal direction. It's a very complicated bit of anatomy if you're going to try and describe it. But we don't have to describe it. We just have to know where it is and what the implications are for tumour or whatever it is within that in that space. And then you can see just how far away mandibular division, which is coming through Foramen Ovale, is. It's right the way back here. So a very different pattern of spread into the brain. through the different divisions of the trigeminal nerve. Vidian canal. Okay, so you can see sort of kind of poetic, isn't it? You know, sort of like tears of joy and sorrow, you know, of the facial nerve. So it connects a carotid canal with the pterygopalatine fossa. So this is what used to be viewed as foramen lacerum invasion, but actually it was tumour spreading along the Vidian canal, and in fact, because it's got cartilage in it, foramen lacerum is infrequently perforated by tumour coming up. It's much more likely that it's got to pterygopalatine fossa and then spread along the Vidian canal backwards. So these are all bits of anatomy around the trigeminal nerves that you have to be aware of and you have to bring up with your radiologist and if you're worried about them. Nasopharyngeal carcinoma is one of the big issues around the central skull base. In the UK, the vast majority of people present at this stage. This is the earliest case I've ever diagnosed myself. We had another early one this year, so that's two really early ones in the last, I don't know, 10, 12, 15 years. So the early cases are pretty rare. We tend to miss them and people present late when they've got to this stage, usually when they've got cranial nerve palsies or some hemorrhage or pain. Spot the deliberate mistake. I show this because it's quite a nice example of why you need fat saturation, okay? I don't think it's very obvious until I put a dirty big arrow there that the pterygopalatine fossa is clearly invaded there. And therefore, by definition, what we're saying earlier is going into orbital apex. With fat saturation, as I showed some earlier examples, it's much easier to follow. And you know, when you're following these nerve roots, you need to go back. So this is Meckel's cave. It is asymmetrical. You can see it's abnormal when you know it's abnormal, but it's just easy with fat saturation on your post-contrast imaging. And then in this unfortunate individual, it's gone all the way around, encasing the trigeminal nerve right back to the brainstem. So this is a nice example of fat saturation and how much easier it is. So you can see that on this fat saturated post-contrast imaging, it's very easy to see what is actually relatively low volume enhancement because of the contrast around in the surrounding tissues. You can see the pterygopalatine fossa involvement coming out laterally behind the maxillary antrum there. So it's much more obvious in this case. This is an ethmoidal tumour with SCC, and you can see that it's much easier to follow with this sort of imaging protocol. That's the in coronal plane. Sometimes this can stand proud and actually on like a pedicle within a particularly large sphenoid sinus, but usually it's actually within the bone itself. And this is just making the point I was talking about earlier about foramen lacerum invasion. It's not usually through the actual skull base, it's back along the Vidian canal, and this is inferior orbital fissure involvement as well, as you can see here. So these are all the exit points, entry points of egress of tumour into the brain. T1 weighted imaging without contrast is actually also, make sure you do it with the fat visible because it's much more obvious, isn't it? Sometimes when patients aren't keeping still, you've got more chance of getting this quality of imaging from a moving patient. And when you give contrast and try and do fat saturation, it's much more sensitive to movement artifact. So just think about looking at all the sequences and doing more than just the very basic set to help you on your way in terms of imaging the invasion that you see from the tumour. And this is just showing you that complex shape of the pterygopalatine fossa. You can see it curves round in that sort of crescentic way that way, as well as the mediolateral diameter that I showed you on the axial images. Okay, moving on. Meningiomas, well, we've been through all this, I guess. Just remember, one of the classic sites is the cavernous sinus. The problem is you can't really get tissue from the cavernous sinus very easily, and so uniform enhancing tumour in the cavernous sinus could be lymphoma, it could be meningioma, it could be granulomatous benign disease. And so it's about clinical context, really, and looking for additional features. So obviously, in this case, you can see all the tumour outside of the cavernous sinus. Interestingly, you can see these are the nerve roots and that being displaced away from that lateral wall. This is where they are on the opposite side, so you can just see the anatomy of the cavernous sinus there very nicely. And that's tumour that's invaded from outside within, I think, rather than being from cavernous sinus going out. Fine, and those are all the different features that we've already mentioned already. Macroadenomas sometimes cause confusion. Because they have a very uniform pattern of enhancement, they can be difficult to separate from lymphoma and plasmacytoma, which I'll show you later, which again don't tend to show necrosis and show this uniform strong enhancement and bland appearances in both T1 and T2 weighted imaging. So yet again, just another example of how imaging, it's where it is that suggests what it is rather than anything about the actual texture or anything else about the tumour. Just remember to take whatever information is on that. This is an enlarged pituitary fossa. So there was something large growing in the pituitary fossa for some time before it got to this stage where there's loads of tumour everywhere. So that's just a clue that it's likely to have been a pituitary tumour. And those are the sort of things that maybe on CT you can pick up more easily than on the MR. Craniopharyngiomas, again, calcification is seen in quite a lot of them, not all of them though. And if you're looking for calcification, I always like to get a CT on these patients when there's any query about it, because you've got a much better chance of picking up the calcification. MR is not that great at calcification. Arachnoid cysts are more common than you think in this area. They can cause quite a lot of displacement of structures, but are usually incidental findings. And remember, the ISO intends to CSF on all sequences, so you can use a FLAIR or DWI, whatever it is that you, diffusion weighted imaging that is, whatever it is that you use, it should be the same as the CSF, so look at the ventricle, is it doing the same thing? If it isn't, think about epidermoid. So that's just the FLAIR showing that it suppresses just as well in this lesion as it does in the ventricle. And in fact, sometimes you get better suppression of an arachnoid cyst than you do in the ventricle, because in the ventricle you get turbulent flow, and that can be more difficult to suppress the signal from, whereas these don't have any flow in them, and so they actually suppress even better on the FLAIR sequence than the signal you get from the CSF in the ventricle. Again, just showing that very bright T2 signal, the same as the CSF. But interestingly, that kind of just makes a point for me, actually. So there between the cerebral peduncles here, you can see in particular fossa, you get turbulent flow there, and so it's actually less bright than on the T2 here, which has got no flow within it. Okay, neuromas, okay, we'll talk about acoustics when we get to the lateral skull base, but neuromas can arise from most of the cranial nerves, and it's more location that tells you what it is. So this is in Meckel's cave, and you can see the cystic tumour, but with the solid components of it enhancing. This is it in the coronal plane, that's it in the axial plane. And it's where it is really, and the history of facial pain that gives it away. Not everything is malignant, obviously. We kind of get caught, don't we, into patterns of thinking. I don't know if anybody's read that book, Thinking Fast, Thinking Slow, but it talks about errors in a really, it's a fantastic book. If you haven't read it, just go and read it. It's a fantastic book. Thinking Fast, Thinking Slow. Anyway, so this is just an aneurysm, isn't it? If you biopsy that, you'll get a shock. Think outside the box. Not everything. This isn't necessarily going to be a meningioma just because it's enhancing and it's in a position where you expect to see a meningioma. Okay. Obviously, it's easy when you get curvilinear calcification like this in the wall. This is a partially thrombosed aneurysm, which is why you get the differential in contrast enhancement. This is all thrombus sitting in it, and that's the actual lumen of the aneurysm. I mean, with CT angiography, it's very easy nowadays to investigate these things. Okay, moving on to primary lesions, central skull base. We'll just have a quick run through these. We'll just do the common ones. So chordoma, chondromas, chondrosarcomas, and plasmacytomas. Obviously, secondaries are overwhelmingly more common than all the rest put together. But that's in a different clinical context, and it's the context that gives the diagnosis. If somebody were to present with just a clival metastasis, it would be very, very difficult to differentiate it from any of these things, really. So chordoma. So as you know, this is tends to be midline, tends to be slow growing, tends to be road bone, complex signal characteristics, very variable. Remember, whenever you're looking at any kind of imaging of the skull base, to look for that clival high T1 signal fat. I've got a friend who works in Leeds now, who says fat's your friend when you're a radiologist, and it's true. On CT and MR, it's very useful to look for the signal from fat and see if it's clean. You do see calcification, but it's very heterogeneous appearance, and that's kind of mirrored in this post-contrast kind of patchy appearance of the enhancement. You can see it's quite expansile, this one. Sometimes they can look really quite different though. This one was initially reported as a pituitary macroadenoma. You can kind of see why. There is very little difference between it in terms of imaging appearances. Now then, chondroid tumours. This very bright signal of the cystic components is characteristic of these lesions. There are very few masses that have that degree of very bright T2 signal. Now the amount of enhancement is very, very variable. But if you see a lesion to the one side of the midline, because these arise from the petroclival synchondrosis, think about these sort of tumours and do a CT, but sometimes beware because the calcification is very limited on these. Obviously in others it can be very heavy, it's quite a variable thing, so you can get really heavy calcified lesions like this, but that's a minority. Many of them actually have very little in the way of calcification. And because of that variability in calcification, you get very complex cell characteristics on T1. Now then, I've shown you the case of the pituitary macroadenoma and the very uniform pattern of enhancement. This is just another example. This is a plasmacytoma, but it's non-specific. I could have put this and labelled it as lymphoma, and we wouldn't have known the difference. And quite rightly, you know, this is a lymphoma. I don't think there's any significant difference in the appearances. So it's about context, clinical history, and being open-minded when you take the biopsies, what you're going to get. This is just my last slide. This is a skull-base infection. What can I say about this? It can look like lots of these tumours at the skull base. So I guess it's about the history of the patient. You know, is it an elderly diabetic on medication? Is it someone who's already been treated for otitis already? And when you're looking for it and following up, don't image too quickly. You know, it takes months for these things to settle down, and the imaging is usually way behind what's happening with the patient clinically. Okay, so don't image too quickly. When you do image, sure, CT helps in terms of bony destruction, but in terms of MR, make sure you do precisely the same imaging protocol each time to enable you to compare like with like. Otherwise, it can get very complicated. When you're trying to make decisions about long-term OPAT or whatever it is you're going to do to treat the patient's infection, it's much easier if you've got uniform protocol imaging. So please insist that your radiologists don't chop and change what they're doing each time. Thank you.